Mike, Penny, do you just want to introduce yourself, a little bit about the work you do, and then we're in your hands.
My name's Mike Basher. I'm a child and adolescent psychiatrist, and I lead the children's eating disorder services for CPFT.
My name's Penny Hazel. I'm a clinical psychologist and I'm the clinical lead for the community children's eating.
So what we want to do is just take you through briefly kind of some of the developments in the service really over the last 10 years. I think if you want to, who's doing this? Why?
And I think it'll be Bethan, Bethan or Natalie who'll be online and who are doing the slide. Yeah. So you just tell them what you want to move along.
Yep. Okay, next slide, please. So there's probably two big stories over the last 10 years in terms of children and young people and eating disorders. Going back to 2015, when dedicated national money came into community services. So even at that point, people were realising that we were admitting too many young people with eating disorders. And we'd already started seeing some rises in prevalence and incidence since about 2000. So there was a massive national investment and training programme called AWT, which was about delivering this evidence-based model, so the family-based model, which is what all community services for children and young people deliver now in eating disorders. So it's using the evidence base from the MAWTI, this family-based intervention, and really trying to drive down the use of hospital beds. And that kind of theme has continued. So the BEAT report from last year, again, pushing this idea of intensifying family support to keep young people at home. So talking about intensive community offers. So we have a home support service ourselves and also day treatments for eating disorders. And as some of you will know, we opened the Beacon last year, which is a day programme. So we're very much kind of online with the national drives. One of the things that kind of threw everyone in the field in eating disorders was COVID. Well, it threw everyone generally, didn't it? But in terms of what we saw in eating disorders was a massive increase in incidence. So that's some national figures in the bottom graph there. So the blue line is the predicted and the red line is what started to happen during COVID. And there's been lots of theorising and lots of thinking about why COVID has had such an impact. And we're still really, I think, recovering from the COVID wave. Next slide. So this is some of our local data. So again, the orange line at the bottom is urgent referrals. So those are the ones that were commissioned to see within 1 week. So those are people that are quite physically poorly and compromised. And again, what you can see is in that kind of June 2020, that sudden upsurge, particularly in the urgent cases, often ending up on paediatric beds, often been quite challenging to manage. And what we've seen since COVID is still, if you look at the blue line, is we're still averaging about 20 referrals a month. And if you look kind of pre-2020, we were probably averaging 10 to 12 referrals a month. So we're still in a kind of post-COVID phase in terms of the numbers coming through. We've seen with the investment from 2015 and further investment, we have seen massive service expansion. So to help us cope with some of this, Penny's going to talk a little about that.
We have the next slide, please. So yes, when we launched at the end of 2016, there were 8 full-time equivalents in the team, and we expanded slightly in the years following that to about 15, but then we had a significant investment following COVID, and we are now 27 full-time equivalents. And that has allowed us to more consistently meet the waiting time targets, which are they're quite ambitious for eating disorders because we know that seeing people quickly is important. So we aim to see urgent referrals within a week and routine referrals within 4 to assess and start treatment. And also a portion of that money has allowed us to develop our home support pathway, who offer support to young people who are really vulnerable and struggling to make change, and they go in anything from 2 to 5 times a week to offer support to the young person and their family in the home to try and build the intensity of the clinic offer. We've also developed internal medical monitoring clinics where we take bloods and provide ECGs, and they've been running very successfully and efficiently in Cambridge for over a year now, and we've started rolling that out in the City Care Centre in Peterborough as well. And we've also been able to offer more parent groups, more psychoeducation and peer support parent groups, and multifamily therapy, which is something we had wanted to do for a time. We, over the years, I think, have been able to work more collaboratively with young people and with carers with lived experience. And I think one of the things we offer now that we are really excited to offer is the peer-led parent support group that meets fortnightly online. And we have supported with helping set up the new intensive day programme that Mike just mentioned, the Beacon, and in fact Mike's a consultant there as well. So yeah, we've changed almost unrecognisably since 2016. And on the next slide, I can tell you a little bit about who we are. So we are really quite a varied and quite a good mix in our multidisciplinary team. We have consultant psychiatrists, a number of clinical psychologists, consultant paediatrician who has a joint role with Adam Brooks and ourselves. We have nurses from children's and adult backgrounds, and social workers, family therapists, dietitians, a peer support worker, an occupational therapist who really helps us think about connection to life, as well as some of the complex presentations that we see, and is vital in helping us do things efficiently. And we work in the CAMHS clinics in Peterborough, Huntingdon and Cambridge. So we work across the county, as well as obviously our home support pathway going into homes or meeting young people in the community. And we work with young people up to the age of 18 who have an eating disorder, including anorexia, bulimia, binge eating disorder, and OSFED, which is other specified feeding and eating disorder, though that might be used for somebody who mostly meets the criteria for the others, but not all of them, and who does present with significant physical risk and social impact of their eating difficulties. And we have consultation to people in the CAMHS system, and some of the Adam Brooks psychological services around disordered eating in the context of other mental health difficulties and around ARPID. Thank you. We are, as recommended by the commissioning guidelines that Mike referenced, we aim to offer nice evidence-based treatments as swiftly as possible. The predominant treatment that we offer is family therapy for eating disorders, because that is where the strongest evidence is for young people. And we also offer CBT, again focused on eating disorders, which is slightly different to general CBT. Multi-family therapy, which brings together 4 to 8 families and really intensifies the work and the thinking that is in line with the family therapy for eating disorders model. So they would meet for 4 successive days, and then some further days more spread out to really try and think together and bring about challenge and make some change. And then CBT informed guided self-help for some of the milder bulimia and binge eating cases. Our home support pathway offer intensive support for around 6 weeks. That can be reviewed if it's working well and maybe extended. We've mentioned the medical monitoring pathway, our carer support, as well as families being a crucial part of actually most of our sessions. There is the peer-led support group just for parents and carers, and there are psychoeducation groups, which we now offer a day in person as soon as possible after a family commences work with the service, and that works really well. And then the Beacon, the still new intensive day treatment. Is there anything you want to say about the Beacon, Mike?
No, we've been not especially been running for a year. Currently got 5 young people, and going through a development phase with the Provider Collaborative, who are reviewing the programs across the region. But we're in a strong place at the moment.
And then our next slide really just aims to highlight that we do not work in isolation. So we are a community team and we have our home support pathway, but we work very closely with the Beacon. and with Addenbrooke's, because some of our young people do need to have acute admissions to support their physical health. And where we can do that, it often prevents things deteriorating to the point that they might need a specialist inpatient admission. So it's another thing that supports more young people to remain in the community. And then young people may need a specialist eating disorder bed or time in a general adolescent unit, but I think we've got some information about that, and that's reduced over recent years. We also work closely with PEDS, the Personalised Eating Disorder Support Charity, who tend to see young people who don't meet the criteria for an eating disorder but might be at risk, and they also might be a good place to step down support too. And then numerous other local and regional services. But I suppose I would highlight that in working in this eating disorder service network, we're also working very closely and often in collaboration with our core CAMS and neurocams colleagues, because there's a lot of comorbidity.
Yeah, and just to add, I don't think the pathways are linear in eating disorders, so people move around various aspects of this network at various points in their recovery. And just to note also that we don't solely use Addenbrooke's, we use Hinchinbrook and Peterborough City Hospital, who we've developed quite good relationships with the paediatric wards there, despite the lack of a dedicated liaison service. So one of the things I think we've done really well over the last 10 years is our acute interface. Next slide. I think we often talk about skills and training and technique, but I think a lot of what we do is relational. Mima Simic, who is one of the national trainers from London, has this lovely phrase about you have to connect to correct. And I think a lot of our work is about developing trust with families and allowing us then to walk this careful path between coercion and collusion. So not colluding with the illness and not getting into coercive practice in terms of Mental Health Act and nasogastric feeding. So we tried to develop a team that has a culture of compassion and that engagement with families and holding on. I think eating disorders is one where it's very hard for families, but also sometimes professionals, to hold on to hope. And recovery is the norm is a lovely phrase that Keith Grimwade uses and talks about hope as being such an important aspect of eating disorder recovery. And some of the other values that our team have been kind of along the bottom there of that slide. But I believe very strongly that the culture of the team and the values that we enact every day are an important part of our achievements over the last 10 years. Next slide. Is it working? So as you can see, most young people spend just under a year in the service. That kind of fits with the national figures. So treatment is generally considered kind of a 12 months. 26 contacts also is a reasonable benchmarking figure compared to what's happening nationally. You can see some of the discharge routes. So most of them are not going into further specialist services, and certainly significantly reduced our demand on tier 4 services. We're seeing, auditing some of our cases, we see improvements in CGAS as you would hope. And we're seeing obviously some improvement in, so MBMI is median percentage BMI. So we don't talk in absolute BMIs in children, but we're seeing improvements in weight in most of our cases. I think one of the things I'm proudest of is our use of specialist beds. So maximum rate of admission kind of during that COVID period, we had 9 young people in specialist beds. We currently just have 1 young person in a specialist inpatient bed. And again, to benchmark that is just 3% of the current regional use. So there's currently about 35 young people in region in specialist beds, and only 1 of those comes from CPFT. And that's, I think, in due to the hard work of the team, the investment in the team, and the work we do across the system. Next slide. I think it's nice to say our endeavours have been recognised. We won the Chairs Award last year. Team have been nominated for Pride Awards, and I think we're a team that continues to be held in high regard within the trust, which is nice to see. And we get good feedback from families. And I just want to finish on what I see as some of the kind of things going forward that are both opportunities for us and perhaps some challenges. So obviously the Children's Hospital, I think, is a great opportunity for us to continue to develop the integrated work. We were recently successful in appointing a paediatrician who has dedicated sessions within the eating disorder service within CPFT. So that's only strengthened our relationships with Adam Brooks, but also brings a greater ability within our team to carry medical risk and to also start thinking about, for those with long-term needs, how we address some of their long-term physical risks in terms of bone health and fertility. I think, like much in psychiatry, things are always shifting in terms of diagnosis, and I think the family of eating disorders is getting broader. I think there's some challenges around ARFID in terms of our commissioning arrangements, and ARFID is something that I think we will need to continue to focus on. In terms of the disordered eating in the context of other mental health conditions, we do a lot of consultation work and we try and support other teams where we can. And there's always that balance of not over-focusing on the eating, because that can become a problem in itself, but trying to manage some of the other mental health needs in an integrated fashion as we can. I think there's lots of interesting stuff happening around obesity and weight loss drugs and the interface of that with eating disorders. And I think that will be certainly something we'll be seeing more of as we go forward. And I think there is always the perennial problem of challenge. Transition to adult services. I think we have a good relationship with the adult team, but I think the models of care are different, and supporting families and young people through that transitional phase is hard work. And I think it's always an area we can improve on, because I think the cultures and approaches are quite different, and some of the parents in particular, their struggles through that transitional phase. But we continue to work on that. We've got another joint away day with adult services later this week. So I think it's a kind of ongoing area of development and thing that we're an area of constant improvement we want to work on. So that's a quick run through.
That's brilliant, Mike and Penny. Really interesting, and such an important area of work, which I have been privileged to visit and actually met some parents and carers as well, who your ears should have burned because they were so pleased with the services you provided and the difference that staff in the team have made, which is what it's all about, really. So very quickly, questions or observations, Mike and Penny?
No, that's a good question. Thank you very much. That was very interesting. I would learn something. I'm a GP by background, and I'm just wondering, we get driven by waiting lists and access to services and those sort of things, but you then did go on to talk about outcomes, which is great. But I just wondered, to what extent do we feel that you're meeting the demand out there? So there's some number of people who come into the service, and I don't know what the threshold is for referral, but there are presumably children and families who don't get into the service. And is there a mismatch? Do you feel we're 27 people are enough to deal with the regional demand or not? Or is it too difficult to answer?
I think we do what we can to try and maximise who's coming through. So part of the work with PEDS is that people can self-refer to PEDS as well as United. And if they do that, they might get signposted to us. So it's kind of fluid if people are seeking help. But we do worry about people who don't come through. Is it enough?
So where do your referrals come from, for instance?
Most are coming through primary care.
Okay.
Yeah. Self-referral has opened up. We're
Schools?
getting a few through schools, and obviously the MHFT teams are picking some stuff up. And we're mostly meeting our referral criteria with a week for urgence and 4 weeks for routine.
And where we don't, it's often that appointments are turned down because they don't suit people.
Thank you.
Okay.
I think Holly had a hand up first.
All right, I can't see around.
No, that's
Right.
I'm just interested in whether you think, because obviously the increase during COVID and that continued increase, do you think that's the new norm? Or would you hope that actually that will decline as people are sort of back to normal and COVID is becoming a bit of a distant memory?
I'm starting to wonder if it's going to stay about the level it is, because it's our average referrals in a 12-month period have been remarkably similar. 12, 18 months. I think in the eating disorders world, some people are seeing it come down more, so that may still happen.
I think it's, we haven't talked about social media today. I think it's changing. We've got 3 of the young people speaking at the moment are young boys. And there's other things happening out there that influence kind of who gets kind of drawn in and trapped by eating disorders. So I think we're not seeing, we still see the kind of perfectionist 15-year-old anorexic girls, but we're seeing a much broader range of challenging kind of different types of presentations. So boys who over-exercise, boys who are into kind of, you know, orthorexic, kind of very healthy bodybuilding. You know, there's a whole different. So I think referrals are staying up, but we're seeing slightly different shift in the profiles. Yeah.
Thank you.
We bring in Kathy, and then I think we're going to have to move.
Comments and questions. So firstly, I think what you've done with the beacon is absolutely amazing. It's a real achievement. And to see that fall in admissions is really something. So well done on that. I also think you've cracked 2 problems which I think adult services struggle with. So that acute interface, that's really positive. And also the medical monitoring clinic internally. I hope the GPs know that that's something that's really lifting the burden from them, because I know they worry a lot about eating disorders. In terms of questions, I just wondered about, firstly, comorbidities. So I'm obviously an adult psychiatrist, and neurodevelopmental problems are very prominent in our adult population, and whether the team deal with the whole kind of presentation. Yeah. And the second question I want to ask was about obesity. So I think, you know, we want to be an anchor institute, a Marmot Trust. Obesity is something that really is partly in the public health arena, but it's something that I'm wondering, are commissioners showing an interest in commissioning services for children that we can contribute to?
In terms of comorbidity, so we see obviously significant levels of comorbidity in terms of the neurodevelopmental profile. Again, the audit we did last year was suggesting 30% have suspected or diagnosed neurodevelopmental disorders. Obviously, there's a challenge around the diagnosis of autism as a system. It's problematic at the moment, but we accommodate where we can. We talk to other teams. We do deliver some other non-ED mental health interventions if we think we're the best people to do it. And in terms of the obesity question, I haven't had conversations with commissioners specifically.
No.
I think what is interesting is how obesity interventions cause eating disorders. So the little boy we saw yesterday, triggered in year 5, year 6 by healthy eating information at school and being weighed in year 6. So I think the overlap and how we approach both sensibly is a very challenging but very interesting field. And then what we're not seeing so much, but I know is coming into adult services, is where things like Manjaro fit in. Because there's a whole other thing about what that does to people, ED psychopathology, whether they had it before or not. So it's a fascinating field, but I don't know that commissioners are yet up to speed.
So we need to engage them in those conversations.
As ever, the world of health is running ahead of us, and humanity has to catch up. Penny, thank you so much. That's been absolutely fascinating, and we are very thankful to you. So please do take back those thanks. We're very proud of the work you do. So thank you, and we'll swap chairs now. Thank you. That's really thank you so much. Right, thank you to everyone on screen while we have to accommodate our moving of furniture. Let me welcome, because I've seen lots of names pop up. We've got a number of new governors with us. That's absolutely fantastic to see. Thank you so much for being with us. Lovely to have you with us today. Formally, I need to note that we've got 2 members of the board are joining us remotely today as a consequence of having to deal with some family matters. So Pri and Karen, you're very welcome, and I know you'll be contributing very actively. And I've got apologies from Jackie McGecky.
Steve Cox as well. Right. Oh, sorry, you're here. Apologies, somebody's put it on the list. Okay. When I got apologies.
No, we should wish a very happy birthday to Steve's mum
Yes.
tomorrow, but he is with us today. So Steve, thank you very much.
Sorry.
So, any declarations of interest that have come up since we all last met? No? As I wasn't able to be at the last board meeting myself, I'm going to go to Karen to just walk people through the minutes of the last meeting.
Thank you very much, Chair. So I will go to page 2 of the pack and start from there. And so if there's anything anybody wants to comment on, because I'll take the paper and the minutes as read. So page 2, then move on to the action log on page 3, the Chair's report, the Chief Exec's report that goes through on page 4, then on to the Board of Assurance Framework and the Quality Matters on page 5, through to page 6, 7 and 8 of the pack, and then finishing up on page, I think it's 14, 11, 12, 13 and 14, I think. So I'm not seeing any hands go up. So I'll take it, Chair, as
Mike has
agreed.
one, which I think is.
Yeah, sorry, Karen. Chair, I've got just one amendment to the minutes, if I may, which is 0725 brackets 11H. And we say we reported substantial assurance in suicide prevention and medicines optimisation. That should read substantial assurance in learning from deaths and medicines safety optimisation. So just things you're correct.
That one, Martin. Thank you, Karen. Then we go to the action log. So the board assurance framework, this has been a work in progress. Can I just check that we are most definitely at the next public board going to get a new version of the board assurance framework?
So the intention is subject to a little bit of finalisation for it to go to BMP, QSPE for a little bit of scrutiny outside of the public board, bring it to the public board, next public board, and then that cycle going forward. It's just taking slightly longer to get to the precise point.
Okay, so it's going through the subcommittee structure and we'll land here because I think it's something we would all welcome. The out of area placement detailed plan, which I think we're still waiting for, Holly.
Yes, that is completed and will go to the next QNS and BNP.
So again, you're taking it to the subcommittee. And can you just remember there are people on screen and the microphone doesn't always pick voices out. Industrial actions, Stephen.
So the genesis of this action was around not just the junior doctors, but an emerging sort of view that actually there'd be a broader hit around industrial action. We haven't seen that materialise as of today. I'm slightly holding onto the table here, touching wood. So we continue to assess that, and clearly if that is the case, we are notified that we would actually sort of raise that as a risk.
And then we were going to come back to Cambridge Children's Hospital to get another session on that scheduled. We're still awaiting.
Yeah, I'll follow those up.
All right. Okay, we can make sure that we get all those actions closed off. Open actions are the bane of my life. So keep the chair happy, we'll all be happy. I haven't been notified of any other business. Assuming you haven't, Martin? Oh, yes,
I'll
yeah.
do that.
Yeah,
I'll do that.
yeah, that's All right, so we go to my report, which I'm going to take as read, but there are a couple of things, there are three things that I would like to draw out, which aren't really in my report. And the first is, far be it from me to insert myself in the world of local, national, or heaven forbid, international politics. It's not my place. I wouldn't be credible there. But I do think it's important, given the work that we do with neurodiversity, to draw out that statements made in the United States this week around the use of what we call paracetamol, what we call Tylenol in the States during pregnancy has no evidential basis or credibility around it in terms of a linkage to a diagnosis of autism or ADHD coming through. And that is something that we need to be very authentic and truthful about, and remind people who, particularly parents who care for children or awaiting diagnosis of a condition, the thought that somebody might point to taking a paracetamol and that you might be racked with guilt as to what you have done is just horrible. And I've had a number of people reach out to me, deeply concerned and upset about that since this news came into the world. In parallel with this, the credence given to a connection with immunisation in childhood and autism and ADHD diagnoses, again, has no credible research underpinning it. And we know many countries, our own included, that not vaccinating children against illnesses such as measles is having really horrible consequences at the moment. So I just want to really draw out the fact that we are nothing if we don't work on an evidentially grounded basis. And we have to stick to the evidence and be authentic to the evidence in the way that we work. On the subject of vaccines, we are really, again, keen that everybody who is eligible should have a flu vaccination. We talked a little bit about COVID in the context of the presentation on eating disorders. It doesn't seem that long ago since, as a population, we were all absolutely delighted to be called to queue up to get a vaccine to help prevent being ill. We have slightly lost our appetite for that. Flu, again, is a really serious illness for many. It's horrible if you get flu. If there's a chance to prevent it, keep yourself and others healthy, I please encourage you to take the vaccine. And then the final thing I would say is that today is Brian's last meeting with us as a non-executive. Brian, you have been an absolute star as a board member. You're going to be much missed. Your ability to get to the point, to be blunt, to be challenging, is something that has been important at crucial times. But you've given a lot to CPFT, and we'll always be grateful to it, and you'll always be part of the family. We will be ratifying, we hope, next week your successor, and you're going to be with us just for a period of a couple more weeks to see your successor settle in. But today is your last public board meeting, and it's right to draw out how grateful we are to all you've done. So I am going to stop there in the interest of time and hand over to the Chief Executive, who will talk about the performance of the Trust.
Thank you, Chair. Good morning, everybody, and thank you for joining us online, for those of you that have been able to. So I take my report as read. There are a couple of highlights I'd like to pick up, which you're probably familiar with regards of late, some changes that you will see within the NHS's reporting framework. So the NHS reporting framework has now got a new performance overview, which is the National Oversight Framework called NOF. So if you're familiar with the word NOF, or you've not seen the word NOF, that's what it stands for. And it is a series of circa 30 odd indicators or metrics, as we would describe, that are the performance elements of organisations, whether they be against their contract, whether they be against the NHS plan, or whether they be against national standards. The NOF, as it currently stands, is then ranked as a result of how you perform each quarter against those metrics, and they're published. So the latest publication of NOF was a week or two ago, and it talks about where you sit in relation to delivery of those performance targets, but also where you sit in relation to your peers or the sector that you operate within. The National Oversight Framework is a framework of 1 through to 4/5. 1 is the highest performing, 5 is the areas, the organisations that require more support. And you get allocated that NOF rating on that quarterly basis when there is an aggregated view of your performance. Our performance and oversight is managed through our Chief Operating Officer and her team, and it also includes some of our corporate functions and some of our delivery functions that are in there. There are other indicators that the Chair's also mentioned, such as uptake of flu vaccination, staff survey, which we'll get onto in a second, and a range of other quality indicators that we would like to include ourselves, as well as the performance indicators. And those of you with a keen eye have noticed that we are scored at, I think it's 2.48, which means that we are defaulted to a NOF ranking of 3, which then puts us in a category with the rest of our peers. Now, the good news about the NOF rating is that it gives us a real sense of insight into how the national team are reviewing performance across the NHS, how the new standards are being put in place, and it gives us real transparency as an organisation to see where some of our hotspots are and the areas where we'd like to focus on. And I think the good thing I'd say about this, Chair, is that there is nothing in that NOF that is a surprise to us as a trust. These are some of our stubborn issues that we're dealing with, that we have plans around for remedy, one of which actually you touched on in the actions arising, which the Chief Operating Officer is taking through the committees of the board, which are out of county placements. The next NOF will be released towards the latter part of October, beginning of potentially November, and that will start to cycle on a quarterly basis. Connected to the NOF is the new guidance that will be issued shortly within the next 2 to 3 weeks around NHS Foundation Trust re-accreditation, and that will sit into 3 categories. The first category is those that are FTs, Foundation Trusts, being reviewed to be re-accredited as NHS Foundation Trusts. Those that are in the pipeline for re-accreditation and therefore are aspirant, and those that have not yet achieved it, that will then require some support to get through the process to become an FT. The guidance, when we receive that, we will break that down as an organisation and review that, because CPFT, by the nature of the fact that we are CPFT, means that we are already an NHS Foundation Trust, and we would like to be re-accredited in that process, and possibly looking at the Director of Strategy and Commercial Development and the HR Director in the first wave, which will mean that we will need to put in additional support to get us through that process, and we'll bring that through our committees of the board so that you're cited on that too. A couple of things I would like to mention. One is the annual members meeting. So we have the annual members meeting coming around the corner, which is the 2nd of October, and we will obviously be using that for twofold. One is to talk about the achievements of the trust in the last year and some of the challenges that we face, and also a bit of a forecast towards next year, the year after, and accumulation of that through the new trust strategy that will be heading towards the board towards the latter part of this year, which will take into account the new NHS plan. The second is our staff awards. We're taking a slightly different tack this time, which is a week of celebrations, and we hope any of you that are dialing in today will be helping us to support some of the staff, including the team that presented this morning, just to say thank you. You know, these people do an amazing job every single day, and sometimes this isn't about one evening where you celebrate maybe 100 odd people. For us as a trust, we want to make sure that we celebrate nearly 5,000 people in what they're doing every day, and give them some spotlight of their 15 minutes of fame, if you like, because they are doing fantastic jobs, and it would be really nice to make sure that we're out and about celebrating. So if any of you would like to join us in that, you are more than welcome. And any of you online that are new governors would like to be involved, please let us know. And any of you members of the public, or indeed any members of the press that are watching, if you'd like to be involved in helping us celebrate that, please do. because this is a great opportunity to get closer to some of our services. The final thing, Chair, I think I'll just raise in the public board is colleagues may be familiar with the fact that not too long ago, we were successful in being accredited as a university hospital teaching status organisation with the University of Cambridge. That then proceeded to be successfully accredited as part of the University Hospital Association, which is a very select group of only 44, 45 organisations in the UK, of which I think we may be 45th on that particular list, which means that we'll change our name. And therefore, we have a small drum roll of how we change our name, and we're looking to the Director of Comms to help us work out where we insert the word university. So we will want to do that because that's a really good achievement for the organisation, particularly celebrating and supporting the prowess that we have in applied research and some of our academic partners that we will work with. And I'm happy to take any questions, Chair, or leave my report there.
Say for the sake of everybody's sake, we might change our name, but we will not change our email addresses because we can't cope with any more confusion at all. Any questions at all, Steve, in terms of this report? Rudolph?
Thank you very much, Chair. I'll just ask about the Foundation Trust reaccreditation. It sounds like a lot of trusts are going to need to do that, and so I presume there might be a queue with the reaccreditation process. Do we get to choose our place in that queue to any degree, or is that luck of the tool?
It'll be an interesting one because my guess is that most FTs will want to be in first wave, and there are quite a number of FTs. So one of the things that the national team are going to have to work out is a phasing process and how we join that queue. How you get selected in there, my guess is that it will be first come, first served basis, but there'll be a phasing like they did last time. But phase one, I believe, starts in April. And then we'll see how many people go through that process. This will be dependent on maybe two things. One is the appetite of providers who want to get through that process quickly. The second is we're not sure what the new guidance means because FTs are quite mature now in their setup in terms of licensing, and the freedoms that FTs operated in maybe 10 years ago are not the same as the ones that we have today. So we're not sure what that guidance will look like and what we need to get through to get from A to B. What we are really clear on is it will be linked through to NOF. So the NOF rating that I talked about before, I think unless you're in a particular category of NOF, then that will exclude you from first wave processes anyway. And when I look across to Stephen and say probably 50% of the NHS is in NOF 3, 3 and 4, that means that it's probably more of a selective group. However, in NOF 3, there's a real clear view from the national team. I understand that some of those indicators in NOF 3 are individualised indicators and therefore stubborn problems that will not preclude you or disadvantage you from going through to FT because you have a plan around them. So that's where we would like to be.
I gather that over 60% of the NHS is in 3 or 4.
Yeah.
So, yeah, well in excess of, well, it's close to 2/3, I think. All right. Stephen?
Really just to pick up one point, the staff survey, it's just to say that we are doing our own sort of internal soft launch at the moment, the staff survey, national staff survey, will be coming out in just over a week's time. And as a board, I would encourage you as you go out and about to sort of, really get behind this and sort of, encourage, support our staff to sort of fill in the staff survey. And if we relate that back to the previous conversation around NOF, it's part of NOF. So we really want to get as many people as possible as completing this year.
Based upon feedback, I'm not sure if we've got any staff governors with us today, Stephen. Staff who've told us it's actually quite difficult to do it in terms of access to kit, having time to do it. How are we actually organising to support people this year?
No, great question. So what we've done is we've gone out across the directorates, asked them what is the best way to engage. So there are 3 different ways this year. There will be the electronic version. People can do it online, they can do it at home, they can do it on iPads, they can do it on their phones, that sort of thing. Secondly, we are taking paper-based versions, though we're conscious we've got to be careful around confidentiality. And thirdly, we're actually going into certain locations with kit in order to actually support people as well.
All right. I think I did paper last year, but I don't think paper is desperately trusted by our colleagues.
The year before we did paper, last year we did all electronic. We moved away, so we're trying to do a combined.
I know we've had paper.
Yeah.
Okay, all right, well, the more we can do to make it really easy for people. That's super, Steve.
And sorry, just to labour this point, Chair, but I think given the fact that we're in a public board and this is a really important moment for us. So staff surveys are not something that are just tokenistic, and I want to put that on record. They are really important. They give us a real temperature check of where the organisation is at and how our staff feel about where we can make improvements. And the one thing that I'm very happy to say from a personal perspective is whatever processes we go through to try and get as many people to give us their views, it's not the only way that people should be able to give us their views. They shouldn't wait once a year to give us that sense. They should continually check in with us, continually be able to raise issues, concerns or challenge. However, this is a point in time review where actually it's something that nationally is recognised, that goes into those areas where we can demonstrate both how we want to improve our performance for our workforce, but also how we benchmark against other organisations, particularly when it comes to this being a really good place to work. People will look at that when they choose a job. They will look at the organisation's performance if they think that this is a career that they want to have with us rather than a trust, maybe different place in the country. So I would urge everybody around the table, everybody listening or everybody reviewing this in their own time, if you do get an opportunity to fill this in, it is not a tokenistic gesture. It is super important for us to get a real sense as to who we are, where we are and where we're going. So bit of a plug. And I think that's also the same for the flu jab, which I think we've suggested that every member of the board that wishes to have one.
I thought we were going to have someone at the door today lining up to inject us, but that doesn't seem to have happened.
It starts in October and we haven't got the vaccines
All right.
as yet.
Yeah.
Next week then.
Yes.
Okay. All right. Well, I aim to be first in the queue. Now, the board assurance framework, Steve.
Thank you, Chair. So happy to take this as read, and thank you, Martin, again for working on a revised board assurance framework. I think, as Martin alluded to, it's important that we take this through the committee to the board to kick the tyres, because some of these are things that are used by committees of the board to determine risk appetite and to determine their assurance back to board. So that will come through in the cycle at the next public board meeting. So one area of note, Chair, which is SA 103, which is against the chief nurse, which has been reduced. So if I could just ask Rachel to give an update on that, and then happy to take any questions.
Yes, certainly. This has obviously been under continuous review for some time. In our recent review, we've, as you say, kicked the tyres on it ourselves and feel that it has been reduced. I'm happy to take any questions on this, but we feel enough assurance and assurance measures are now in place and are being thoroughly monitored throughout the process. In particular, we did remove the improvement board, which was closed down some time ago.
Yeah. And if I may, Chair, one thing I've just offered the board, maybe not in a public session, but in a development session, is one of the key controls against this risk. You'll notice is the PSERF process, which is an incredibly robust process. And particularly for colleagues around the table that may not be familiar with that, or indeed governors, it may be a good opportunity for us to run a bit of a session on what PSERF is and how that determines assurance through our committees. So
Just want to explain, PSERF, what it stands for.
Yeah, it replaced the old serious incident framework some time ago, and it stands for Patient Safety Incident Reporting Framework. And it's been, as it's been in place some time. It's very different. It's very much about really a just culture, non-blame. Certainly, feedback nationally was the previous process. Staff often felt blamed and criticised in their daily practice, as opposed to what is the learning. I think some of the challenges with the PSERF process is that the actual report, the investigations, in fact, we move away from investigation, but the investigations do take a lot longer. It's far more engaging with families and staff and get that learning very much bottom up. We have done a number of sessions in board development for the board. More than happy to do other sessions or reviews with updates with staff.
Can I go to just ask Mike on this particular lowering, and then I'll come to you, Steve.
So PSERF, patient safety response framework, is something that we have taken an interest for as long as I've been chair of the committee. We report on it every meeting, so bi-monthly. And we not only look at PSERF, which is the sort of most serious safety incidents. We put that in the context of looking at safety, the smaller day text safety incidents which come through. And so I'm assured that we've got a good mechanism for looking at safety incidents. That said, it's always a challenge to make sure the learning is trust-wide, and that's a question that we keep asking at the meetings. But PSERF sits in the wider trust-wide approach to safety and safety incidents in terms of preventing them and learning from them.
Steve, do come in.
Yes, a separate
Yeah,
one,
that's
yeah. So yeah, thanks, Steve. Looking forward to seeing the revised path at B&B some performance committee in October. Just had one specific question on reference essay 401 on revenue resources, which is that there's a risk the trust will not have sufficient revenue resources to deliver services. Any question, the target risk score has a likelihood of that being 1 by the end of the financial year. I just wonder whether you thought that was realistic.
I'll look to Kish in terms of an answer on that. And I think as we start to get through the next stage of our financial planning, I think that should be reviewed through BNP with your agreement, because I think that feels optimistic, overtly optimistic in this certainly current climate, but I think it would probably warrant a full and frank review as we get towards sort of month 5, month 6 through BNP, Steve, if that's something the committee can take through.
Yeah, certainly.
And just comments up. The reason for the current rating is because effectively we are forecasting that we will be break even. Our position year to date is break even. But you are correct to say that there are risks with that, okay, that we do need to assess as we're going along. And there are emerging risks which suggest that that may not always be the case.
But to be absolutely clear, we have a statutory duty to deliver break-even budget, and that is what we must do. That is the duty of the board, and so we've got to make that risk work for us, for understanding it. Okay, any more questions on the back before we move on? Thank you very much. In which case, Mike, I go to you as chair of the Quality, Safety and Patient Experience Committee to just have your report.
Thank you, Chair. So this is the report of the meeting of the Quality, Safety and Patient Experience Committee, subcommittee, of the 20th of August. 3 things I perhaps want to alert to. The first is our concern, which has been present for some time, around our waiting lists, in particular the ADHD waiting lists, the high demand and long waits. A number of actions have been taken to try and address that in terms of helping people wait well and safely. But ultimately, you want to reduce the number of people on the waiting list. What we heard in August was that the ICB is commissioning private providers to help reduce the trust's waiting list. So we await to see the impact on that. And obviously it has an impact on operational performance, but also quality and safety. People waiting on these lists is not satisfactory for their psychological health and other things too. I've reported at every meeting that the provision of ECT for patients with resistant depression in the south of the county has not been provided since the service was stopped during COVID, and that remains the case. And whilst CCT is available in Peterborough, so people can access it, that is not a satisfactory position. And the Chief Operating Officer is very keen to bring a paper to the next board to give us a position statement on what the plans are there. And whilst I've mentioned complaints here, I know that Anna Took is coming later. So the area of interest around patient experience issues Can I leave that to that paper so that we can discuss those in detail? You're going to do that, I beg your pardon, Rachel, yeah. Just wanted to do other things. We have now seen the first well-led improvement exceptions report in the light of the well-led CQC, and that will be coming back in terms of progress as a standing item on our agenda, and I'm assured that our relationship with our partners in the CQC is good. The Croft Child and Family Unit for children with mental health problems has been paused, and work is underway to look at how that model of care goes forward, a bit like what we heard with regard to eating disorders, moving to a more outpatient model. And we're very proud of the virtual ward for clozapine treatment, improving access. I think we're the first in the country to do that in Peterborough, and there's work ongoing to extend that service across the county. I'm at the risk of reading the whole report out, so I will move on. I'll just pick out one or two other things that are, I think, important. The first is the anchor institution and the move towards a Marmot accreditation, where we supported this trust signing up to the anchor charter locally, and I think that will be going forward. And we also had two very important strategies coming forward. One was the health equity strategy and the clinical strategy, and those are two very important pieces of work, and the final clinical strategy paper will come to the October board, and Kathy, you might.
And on to board in November.
We've got mental health coming up later on this agenda. And the last thing, very importantly, in the light of our SIP programme, efficiencies, and also service redesign, we are interested in both the policy process and implementation of quality impact assessments. So we look at not just the financial aspects of that, but what are the consequences for quality and equity when we embark on efficiencies. And so we received the quality impact assessment policy and process that will be updated, and we look forward to hearing about equity impact assessments at the next meeting.
Any questions at all from Mike? Rudolph?
So firstly, great to see progress on out of our placements. That's great for quality as well as the money side of things. I was just going to ask about the rapid tranquilization and observations after that. So we've got this, it's on page 68 at the back, but the proportion of people who get observations every 15 minutes recorded properly after that, not super high. And I was wondering whether we got a sense of whether that is because they're not being done, or whether it's because they're being done, but it's difficult to record it with quite that speed, and whether we can.
I was going to cover that off in my next report, but I'm happy to.
Why don't you answer that now?
I'll
It was one of my questions anyway.
Yeah, so you're absolutely right. So there is a disparity between the EPMA data and that input on system one. There is a deep dive happening. Doing a deep dive in next week, week after, into the July data to see exactly where the disparity is and why. And then we'll be taking that back through to Quality Safety Commission's experience. But yeah, we don't understand why it's happening at the moment. It's being looked at, so they're doing a fuller looking at all of the data for July.
Ish, let me bring you in.
Just one question on the ADHD waiting.
Can you just make sure everybody can hear you?
Yes. On the issue of ADHD waiting list reduction by third parties, okay, that the commissioners are introducing, is that expected to have a knock-on effect to our list?
I defer to Holly. I mean, what we heard at the Quality Committee was that this was a welcome intervention, and it will mean that some people are seen sooner than they would otherwise be seen. But actually, given the rising demand, in terms of turning the corner on the waiting list, it's likely to have no or minimal effect. But Holly, you can.
Yes, certainly. So the current waiting list will be prioritised. So we will retain responsibility for those with higher need who require the sort of specialist secondary care level assessments and potential ongoing treatment. The other people on the waiting list will be offered the choice of a number of providers. And at that point, they will come off our waiting list and they will continue their care through whichever provider they chose. The new people coming onto the waiting list, there will obviously be a revised referral process so that again, only people who require our level of skills will come onto our waiting list. So it's a big piece of work. We've talked many times about the number of people on that waiting list. So we do expect to see a reduction. Will it enable us to be able to see the patients in as timely a fashion as we would like? Probably not for a number of years because the size of the waiting list is so big.
So I get the volume. I think it's probably worth drawing out the change complexity that's expected at the trust and the implications of that for the quality of service we can provide. That might be just something to consider.
Can I just ask everybody to please try and project your voice?
So I think that's a very helpful intervention, and will, in terms of the complexity of the patients that we're seeing, if a number of patients are going off to see private providers. So we'll certainly come back to that at the next committee meeting and get an understanding of what the implications are, magnitude of the
Okay. The important thing to remember is we talk about waiting lists. Waiting lists are made up of people and those that care for them. And being on a very long waiting list, and all you want to do is to be seen, to get a diagnosis, to get treatment where that is possible. So we've got a collective duty, not just ourselves, but the wider system, to make sure that we are moving people through as quickly as possible. And whoever the provider, ourselves or a private provider, it's got to be of high quality and people must be able to have confidence in what is happening. Let me go then to you, Rachel, for the quality report.
Thank you. Yes, and as always, take this read. And I've moved off by having explained the rapid rank. You'll see it on there as well. And as I explained, that will go back through the Quality and Safety Patient Experience Committee. I'd also like to highlight the lengthy segregation on George Mackenzie House, and to explain that that's obviously being closely monitored and is in line with clinical practice. There's no issues there. I think it's worth noting that. In terms of the effective trust-wide oversight of cause and prevention, I think it's really important to also explain that the lying and standing blood pressure recording has improved 30% since the last reporting. That there has been obviously a clear improvement plan that continues to be monitored by the modern matrons and the head nursing within OPAC. So we're hoping that we will achieve targets in the future. I won't talk about complaints here because that will be in the next report. The only other aspect that I think we do need to acknowledge is in terms of DATIX reporting and some of those incidents being signed off appropriately. We are being, it's being affected by staff capacity to do that. When we talk about capacity within the teams, in terms of the review, the patient safety team are supporting this. Regular reminders are being given, but we, in line with what we talked about in terms of resource and waiting lists, we are seeing an impact there, but we will continue to monitor that.
Okay, questions?
One additional issue that we are concerned to monitor is sexual and physical safety incidents, which we report on regularly. And again, Jim Ledbetter advises us on how that is being monitored and dealt with through what's called the Barnes Profession Restrictive Practice Group. So that reassure you that we're looking at it, and we'll get assured.
That relates to the rapid tranquilization.
Okay. I mean, I think, I've said this before, the NHS is a very busy place at the moment. We are no different in that, but there are some things about recording and post-instant reviewing, which is actually part of core business, and kind of got to be able to be in that zone consistently, I think, Rachel. So I think we'd be grateful if we can understand how we can work collectively to make sure that that is happening. Can we then move to the report on patient and carer experience and PALs and complaints, noting that Rick has put in the chat about understanding that there's been reductions in staffing, which
we are currently going through a consultation into its within the nursing and quality portfolio. There hasn't actually been any direct cuts in the PALs team.
that was my understanding. It is as it has been proven. So let's take the patient and care experience of PALs and complaints report.
Yeah, I'll continue with PALs and complaints, and everybody will know that this has been an issue for some time. In terms of the complaints response times, what I do want to be explicit about, that this is the third quarter in a row in which the average response time has reduced, if looking at the data very clearly, despite the issue that across the trust we have increased contacts, increased activity, and therefore increased complaints. And that's at 90% on this time last year, Q1 last year. So with that in mind, if we hadn't had that increase, we'd actually be meeting target very well if we looked at that trajectory. We have had an improvement plan in place. A number of measures are now beginning to have a positive effect. Within that improvement plan, there was a full process mapping of the whole quality checking process and making that far leaner. Within that, we've also just completed process mapping of the escalation process. That escalation process happens if the investigating manager doesn't submit the investigation pack on time, and that is now escalated far faster. And I would thank executive colleagues for supporting that to date. And that has meant that we are, again, reducing. We have also been in liaison with system provider trusts via the System Quality Group. And this is a picture that other provider trusts are seeing locally and across the region. There was very helpful discussions. Some are looking at their targets. We're not as yet. And if we do have that discussion, I'll go through the Quality and Safety and Patient Experience Committee. But I would actually like to be thanking not only the team, but the investigating managers across the trust who are, and again, Eileen, I would agree with you, this is core business and part of us improving what we do. But I would know how weighty some of these complex complaints can be.
And I think it is worth setting out, we're not alone in this, but the greatest proportion of uplift in activity about people raising a concern or a complaint is about waiting times.
Yes, yeah, common themes, waiting times, access to services, communication.
Yes, which we have got to get better at. Is there more you wanted to add?
No, Rachel, to take a question.
Okay. Nick and Steve.
Thank you, and thanks, Rachel, for two things really. One, for the report, but secondly, for taking on this portfolio, because one of the things that we wanted to make sure when we did the portfolio changes with the executive directors was that complaints fed its way directly back into quality and lessons learned. So rather than being separate, it was really important that complaints obviously fell in various categories of either concerns or issues, or where there were opportunities to improve, then they would be taken as part of the quality improvement aspects. So that bit's really, really helpful. I think it is worthy to note, as Rachel had said, the performance is improving. It's part of our well-led review as part of the planning run-up, which is great to see. I do think, Rachel, one thing that we are not able to report because it's difficult to, is the complexity actually that's coming through now from complaints, because they are very different. There's a significant number of AI-based complaints coming through, which are armchair lawyer standard, shall I say. You know, they are so difficult to unpack, which means that actually by the time you've got to the bottom of the real complaint, you've had to go through various processes to go from start to finish, which is something that we probably now need to start talking about in relation to our targets, because that's really important. But I think the most important thing here is that this is part of now the quality framework that we have as a trust, and it's built into our quality improvement. And so we should start to see both a net reduction in these, but also an increase in lessons learned that comes out of these. And we do the thematic reviews of these as we do an annual cycle of this anyway, which will capture.
Yeah, and we do have a triangulation meeting with the other corporate teams and clinical teams and bringing all those lessons learned together.
Okay, I mean, it's a very full paper with many themes within it. There's just a couple of things. You want to say?
I was going to have two other points to make. So,
Go on,
sorry,
Rachel.
sorry. Two other areas from the report that I would like to highlight is the work that's taking place within Children and Young People's Directorate. And again, going back to the waiting list issue, as you've highlighted, Eileen, they are working with Family Voice and Pinpoint to improve the information to provide to young children, young people and their families who are on the waiting list. And they also have as part of the trust quality priorities, there's a care planning project that commenced in April for Children and Young People's Directorate. And the project aim of that is to ensure care plans are based on what matters most to the children and their families and maximising their strengths and preferences. And that's already having some good effect in terms of care plans being completed in better. And similarly, in terms of the community mental health survey, the report was received April this year. It will be going on more detailed. The action plan will be going through to Quality and Safety Patient Experience Committee in October. There's many areas the areas that we were doing well in last year have been sustained by sustained food. However, care planning again is an area that we need to look at. We are looking at the Dialogue Plus work stream, and I'd urge people to look at the Trust website, which explains Dialogue Plus fully and the project that's happening. And again, that will be having a beneficial effect.
Anything else?
That's it.
Right.
Yeah, so I did two additional things. So we focused on PALs and complaints, but the patient surveys are part of how we get a window on patients and carers' experience of our services. So on page 11, you've got a summary of some of the data from the community mental health survey, which Rachel's talked about. The other thing I'd like to sort of commend Anna on how do you take all this information from complaints, PALs, surveys, and turn it into something which is helpful for staff who provide care to our patients, so they get the meaningful message from what is a huge amount of data, and bringing that. So she's working very hard using AI and other mechanisms to turn the intel that we're getting into something that is useful for frontline staff. And I think that's starts to close the loop in terms of making sure that these messages are understood.
Thank you, Mike. I mean, I've made this point a number of times, so I slightly have repetitive point syndrome going on here, but it's about feedback we get about in the bottom area of feedback, which is about the people not feeling supported to rebuild their lives after a period of mental ill health, which puzzles me, given that we do have some services we offer already to certain people who use our services around employment. Can we not do better with that? Can we not engage with others, as other trusts do, to actually make sure that we've got services that support people on money, on housing, around us and with us? It's not sufficient to say not our problem, because actually getting people well is our mission, and these are factors that enable people to get better. So I really do think we've got to get better at this. Kathy?
Yes, so I think I mentioned this at a previous board meeting, but we've actually had a meeting with the Citizens Advice Bureau. We have some grant funding, which we are going to do a pilot of introducing a citizens advice worker 2 days a week in both Peterborough and in Cambridge to try and help people to address housing issues. It will also support some employment questions, etc. So I'm quite excited about that as a potential way forward for some of these issues.
Well, no, I do remember you saying that. I mean, it's great to pilot it. These are well established systems of the trust, so we kind of need to move on.
Well, we obviously it costs money, and we're using our grant funding to do it as a pilot, and hopefully we will be able to find a way to sustain it.
Well, I think other trusts find it helps with discharge as well. So the probably the self-funding. All righty. Any more questions, observations there? Okie dokie. Kish, continuing the delights of the morning, can we go to the finance report?
Try to speak up to the microphone. So just taking the month 5 report as read, then I'll take questions at the end. Just the main highlight issues. Cash remains strong. We've actually had the main debtor that we had outstanding settled last month. We've actually had the second largest debtor now settled as well, which is H-put. And so I'm expecting cash to remain relatively on track compared to where we are. But the organisation has a history of strong cash. It's not the most material issue. Turning to capital, the organisation is currently slightly underspent, driven by IT. Largely, this is about timing, and I'm expecting this to be rectified as soon as the Windows 11 rollout catches up with where we are spending the money. So again, I'm not expecting an issue from the current underspend. Forecast-wise, however, there is a larger issue. There's clearly a hockey stick in Q4 with regard to estate spend as a result of the 2 material cases that we've moved either last board or before on Springbank and name I keep the other ward I keep forgetting. Okay, Beacon. Thanks, Steve. Beacon. And then there was a risk there that we might not be able to spend the money because of that hockey stick. The centre have offered to be able to broker spend across the 2 years without it impacting the organisation's plans. That is going to be taken up. So that risk should also then be mitigated. The amount to be brokered is approximately £1 million. Turning to the material item in the report, IND. IND is currently on track year to date, so we are break even. It is worth noting the position is supported by a significant amount of non-recurring items. The month 5 position itself did show some underlying improvements, which have been offset, I have to say, by some non-recurring adverse movements, both of which I'll comment on now. So the improvements, first of all, sustained odds reduction. Okay, so you'll remember that at month 4, I said that this was the beginning, it couldn't be taken as a trend. There are 2 points now. Those of you that are statistically minded, that still doesn't constitute a trend, okay, but it is moving in the right direction.
Out of area.
Yes, out of area treatment. So that's the second month, okay, and that has helped. The other item that has materially helped is non-medical agency has continued its downward trend as well. Okay, so that has had an impact, and both of those things have resulted in a month 5 improvement, it should have been approximately about £500,000, £5,600,000. Unfortunately, things have gone the other way as well. We've had what was expected to be an agreed outcome from FENS, okay, which has not developed as expected. And on top of that, there is a risk on the organisations charging as a result of inflation, okay, on Cavell, which has been taken into the position. At this point, it is to avoid issues that have occurred in this organisation previously, where in the last few months of the year, we've had an issue with PFI. It's possible that might still go in our favour, okay, as we approach the end of the year. At this stage, I think it's worth taking into position as opposed to a risk that emerges later. Just risk mitigation. That's year to date, okay, and in month. The forecast position is currently still break even, but it is heavily dependent upon delivery of the cost improvement programme, which to date has been supported by non-recurring means. So it remains an area of material risk in the organisation's forecast position. I think the last thing I need to comment on is that what is not in the report and what was not written at the time that are new. There are beginning to be emerging income risks as a result of the service changes, okay, that we have made in the first part of this year. Some planned, some unplanned. I need to get to the bottom of whether those risks are going to emerge or not. They may well be material.
Okay, thank you, Kish. So, as I said earlier, we've got a statutory duty to deliver a balanced budget. So that's work on. I'll go to Steve and then to Brian.
Thanks, Chair. Thanks, Kish. The income risks, clearly that's something we need to hear more about once you're able to share with us. On the capital spend, good that we've got that bridge into next year. I'm sure it will keep the pressure on to spend at the beginning of next year rather than seeing that as something that can come through later next year. Just on the non-recurrent, I just welcome your thoughts on the dependency on non-recurrent savings to hit the cost improvement programme, the risks of that. Share with us for this year, but also for next year, 26-27. And if I can, if you could say a little bit more about the final paragraph, which says that focus on the margins will be insufficient and service redesign will be required. If you just unpack that a little bit as well, that would be helpful.
Yeah. Let me know if I miss anything. Okay. So I deal with them each in turn. The non-recurrent this year to deal with the cost improvement programme is on one hand an argument about it's slow to start, but we intend to do it. And if that argument emerges into physical action, then the risk is minimal. And that's why forecast remains on track. That is an assumption. If the actions don't emerge, then clearly the non-recurrent will fade out at some point. By its very nature, it is non-recurrent. So, and I don't have an unending amount of balance sheet to be able to deal with that. So that's the key issue. The point that you make about the non-recurrent impact on next year is very, very important. So this historically, not just for this organisation, but across the NHS, has been an issue where organisations have used non-recurrent means one year, that have then come back the following year to be addressed. The guidance at the moment is pretty clear. You expect to be a variable for this year as well. The full year effects are not means by which you, in effect, count them as SIP for this current year. They are to be addressed as part of non-recurrence. So in our approach, if as is correct, the non-recurrence are timing issues, okay, the full year effects will deal with those timing issues. So the two issues are meant to balance each other out. Where they don't, I suspect, but this is a suspect statement as opposed to a known statement, we will have guidance that suggests, okay, urgent action needs to be taken in year to address those. And I expect that guidance to come out alongside the planning guidance in Q3. But even if it doesn't, to be honest, sustainability requires probably that we need to one way or the other anyway. And if we know about it, then we should address it in year. So fully reflect on non-recurrent, but it is very important because for the size of the organisation and the size of the non-recurrence that I'm dealing with, could well add to about 2% for the organisation SIP programme for next year, which would make it into that point I make in the last sentence that you referenced there. Doing things at the margins is clearly not having a sustainable impact. Identifying things that we can efficiently change with what we are doing is not having the outcomes that we need to deliver services sustainably. We need to change those services so they can be delivered sustainably. That's what we need to see.
Well, that needs to be done quickly. Brian.
I was going to ask the same question, but my follow-up would be really probably for Steve. Is what's your confidence level of achieving the current year SIP?
As it stands at the moment, my confidence in the plans is higher than the output of the plans on the basis it's taking a while to get some traction against them. What I have seen though is a detailed set of plans that are now going through the trust efficiency programme that have got some month behind them. And I think the one thing that we need to understand as an organisation is when you start to see consultations within changes to services, then we as a trust have to write that bit out, because this is about changing the things not around the edges as Kish is talking about. It's making the material changes which staff will struggle to understand because it will directly in fact impact on them. And so we'll have to do that with a level of sensitivity, but I'm clear across all of the service savings I've seen that those plans are in place.
Good job.
About these financial matters, so apologies for this, but I see in the 10-year plan that one aspect is the move towards paying for what you do rather than just giving just like it has a bunch of money. And the difference, of course, is that if you can make a service more efficient, if you can see more people, then you might get more income. Do we have any sense when that mechanism is likely to start to happen? Otherwise, we're just fixed about money and looking at saving money.
Do you mind if I try and do an amateur version of this, Kish, and then if you back me up with a more professional version? I'm very worried about that narrative, because in the parallel narrative of we shouldn't be competing with each other, then what we don't want to try and do is start to say, come to us because you'll be seen quicker, or come to us because you'll have a better outcome, because then we start getting into an internal market over attracting income lines with cost per case almost. I think the bigger concern I've got, though, alongside this is if organisations are incentivised to do that in that way, then I'd be really worried about quality oversight of the intervention itself. Because by definition of seeing more people quicker, the chances are we need to be careful that what we don't do is do that with lesser impact, lesser quality, more readmissions, more risk, etc., etc. It's something to take on board, but my worry is that that won't be an incentive if we're not careful. Most services nationally at the moment are overstretched with regards to demand. And dare I say this, Rudolph, but commissioners only have a certain amount of money anyway. So the chances are if those services are overstretched as it stands, one provider taking from another is probably not going to help. Sorry, Kish, that was my amateur version.
It is a key plank of NHS finances going forward that organisations will be incentivised to treat more patients. The idea that block funding will continue, I think, will be misplaced. In the current year, we are being asked to disaggregate our block, from Cambridgeshire and Peterborough in particular, but also the other smaller commissioners. Basically, disaggregation means there are more complexity than this, but in short, take the total amount of money you get, divide it by the total number of patients, compare it against the price that you should be getting for those. In that scenario, there are two competing things for this organisation. One, the average price for those patients is lower because the reference costs for this organisation are higher than the average. That's the first point. The second point is always one about data. So mental health trusts and community trusts don't have standard data. You can't deal with them in the same way as you can with acute trusts. So there is a big debate taking place about the how do you do this in mental health and community? This is a debate that's been going on for 20 years. It's not new to now. How that gets resolved, I don't know. But this is the first time I've seen it where the question being asked is not whether we do this, but how do we do this? So I do think some kind of incentive mechanism that is aimed at treating more patients is likely to come about for mental health patients in particular, possibly community as well.
Super. So many challenges. Let me go then to, if everybody's okay on the finance item, Stephen, we'll go to you for the people and agency exception report.
Thank you very much, Chair. So I'm going to take the report as read, but I just want to highlight a couple of key areas. And so we've got a relatively broad spectrum of information in this report. So just to alert the board, we are seeing that increase in our employment-related cases. And again, we are going to do a deep dive into just trying to understand some of this, what's happening across the organisation, though we do recognise, and as we have discussed at People and Culture Committee, we are doing a bit more of the focused work around sort of sickness and supporting our director and corporate colleagues to sort of like help and support staff during both short and longer term sickness. The advice section, we are talking around a number of metrics that are sort of going in the right direction, time to fill, sickness, turnover, etc. And then in order to, around the assure section, we continue to meet our requirements around sort of mandatory training, mandatory training for role. Vacancy rate remains under at 10%, so at 9.04%. And we've seen our sort of fill rate increasing to 95%, and that's around bank and agency as well. And finally, just to say that we did launch our sort of our each person staff recognition platform during the reporting period, and we've had a significant sort of buy-in to that piece of work as well. And again, in the report, there's some additional information around what that is. And I would encourage you to go on the internet as well, intranet, and have a look and sort of sign up to that. And we'll be using that to do a number of things, including our Pride Awards, long service awards, staff recognition, etc. I'm going to stop there and answer any questions.
Thank you, Stephen. I'm just going to check with Pri. Pri, is there anything you would like to say as chair of the People and Culture Committee?
No, I don't have anything further to add at this point. Thanks.
Question, Kish.
So can just check out you in terms of the agency, is that part of this? Can I just make a point which might be helpful in terms of reconciling the finance report against the agency report? I think the agency report includes non-recurring items that I mentioned in my finance report, which might be depressing the numbers. So it might be worth just removing those to give the picture of what we're doing.
I think that's really, really helpful, Kish. And again, there probably is a broader piece of work that we've been talking around in the exec around. There's an interesting dynamic at the moment around, we're still seeing medical agency costs at high, and we've seen the rate remain high. There's a piece of work potentially at a regional level around just trying to drive down this through the procurement hub. So I do think we need to sort of step, and actually maybe when we use our procurement, our provider collaborative, should I say, in order to try and sort of get a combined approach across the eastern region around sort of medical agency rates. I think we do need to challenge that. What we are seeing is, you know, as you can see in the report, we're doing well when it comes to recruitment around medical agency. On the other hand, you know, at demand capacity, we're still seeing we're paying significant costs associated with agency rates.
So I agree with you, Stephen. I think actually it helps as national as opposed to regional, because the thing is that locums are a national pool and they'll go where they get the best rate, essentially. I think the data and the report slightly hides some of the significant progress that has been made in terms of medical agencies. So part of the reason for that is that it takes about 6 months to get anyone into post, and that's a minimum. So we've seen a significant increase in the number of candidates applying for jobs. We've made some very successful appointments recently. The adult and specialist service, their trajectory is that as of December, they will have no substantive vacancies and all those posts will be filled. children and young people, it's rather similar, but we've now got a couple of retirements and 2 leavers for personal reasons. So, you know, that's what happens. That's the chair. Our main challenge is older people. And we do have some thoughts about, and don't panic, an invest to save scheme, which would actually be much less expensive than our current locum expenditure. So I feel very encouraged by the huge amount of work that the clinical directors have been doing to try and address this problem. And there's a definite downward trend, definite increase in what we're seeing in terms of the attractiveness of our posts for people outside.
Okay, well, having chaired a number of panels recently that brought consultants in, it is great to see not just quantity but quality coming through, which is brilliant. Okay, any more in terms of what Stephen has drawn out? I did have a curiosity, Stephen, which I raised with you, which is we've got, it would seem, an awful lot of bank and agency resource going in to cover compassionate leave more than covering annual leave. I'm just curious as to whether that's an aberration or whether it's a trend.
No, I think it's an aberration. We are going to just look at that again. I think there may be just some recording issues around whether it was annual leave or compassionate leave. So we're going to look at that.
Grateful on that one. Karen.
Thank you, Chair. Just to pick up on a point I think you highlighted is around the disproportionately high referrals from adult specialists into our wellbeing service. And sometimes it's looking at this, is that positive or is there something going on that we should be concerned about? So it's a question for Steve in that, what's going on in adult specialists?
Thanks, Karen. So obviously we did the deep dive around the health and wellbeing service through P&C. Clearly that was prior to this sudden sort of increase. Now it's the first month we've seen such an increase. We are going to look at that because again it's around 2 very key areas. One is around mental health and one is around MSK. There is a question mark around that sort of mental health element around, is it as a consequence of what's going on from a local perspective? Is there something else driving that? So again, we'll bring that through either to board or P&C.
It'll be a segue into the report we're going to receive next, but obviously it's concerning that we've got an increase in number of employment cases relating to global majority staff. Your thoughts on that?
Again, we did a piece of work for the last P&C around that. We'd seen a slight increase over a sort of a more protracted period of time. We didn't see any sort of correlation between were there particular issues, were there a particular sort of focus on particular groups, etc. We couldn't see that in the correlation. Again, we will do a bit more of a deep dive around that. There's a sense that this is a one-off in month, but again, we just need to relook at that.
I'm sure you and through People and Culture Committee will want to come back to that and just really give it a good scrutiny. Okay, any more on that one? So Sharon, nice to have you with us. You're here to invite us to note the report that you provided on the race equality standard and the disability.
Lovely.
So if you can be brief just in introducing.
Sure. Yes.
That would be helpful.
Lovely. Thanks, Chair. Thank you. So I'll take the papers as read. I think it's really interesting for you to note that this year we did something very different. We did an analysis over a 6-year period. It's something that we haven't done before, and we also linked it to model hospital so we could see a bit more of a trend and look at the analysis. So that was really interesting to look for patterns. Very quickly, I'll pick out probably just 2 points. I think for the DES, the Workforce Disability Equality Standard, I think we could see that just under 1 in 7 disabled staff experience some sort of harassment, bullying and abuse from their managers. Why I think it's really important to look for the 6-year period, which we hadn't done before, is we could see during COVID it dropped. So it dropped in 2020 from 14.6 to 10.50. So that's only a 4% drop, but a lot of people were working at home. So we actually could see a correlation between when people were working at home, they weren't getting the abuse, etc. so much. And it's increased since people are back in the office. And that's compared to non-disabled staff of 8.4% in 2020 to 4.8% in 2023. So you can see, obviously, BME disabled staff, are higher, getting higher experiences of bullying and harassment, but obviously it's still not grand at all. However, I also want to mention disabled staff had reported a decline in stating their reasonable adjustments had been made within their workplace. It's gone down from 81% to 75% in 2024. However, when you look at model hospitals, so having the various data points is really good. We are in the top 25 percentile compared to other hospitals when we look at our peers. So although we're having some challenges with reasonable adjustments that we are really addressing, we're still doing really high compared to others. Really quickly, the rares, bit of a mixed picture. There has been an increase in global majority staff being employed in the organisation. So this rose from 20.55% in 23-24 to now 24.07. And it's very similar to our population of Cambridge and Peterborough. So it's very reflective. There has been an increase of 2.36% of global majority staff experiencing harassment, bullying and abuse from patients, relatives and the public, from 26.39 to 28.75. And there is a slight increase of global majority staff believing the trust provides equal opportunities for career progression. And nearly half of BME staff believe the organisation provides equal opportunities. So all of this we've put into our 1-year operating plan. So as you know, we've completed our strategy. And falling out from that, we're doing a lot of work about keeping that evolving, doing little video pods, doing little drop-in sessions that we've got starting this week to make sure people can come and engage with it and really think about how they can have this as a golden thread through their pieces of work. And I think if we can have one thing really, it would be better data reliability and validity, really, in terms of where we get some of the data from. So we've had to do a lot of cross-checking this year in terms of the data sources. So to have a one touch of the button, res and des, would be absolutely amazing. Just to give you a very quick second, in terms of the operating plan, the main focus of our work probably this year is around focusing on those reasonable adjustments, because we've got massive areas of work, written policies, etc., etc. So that is a big focus, as well as improving the res and des score. So I'll stop there.
Thank you very much, Sharon. Super interesting and incredibly important. Questions or thoughts? Brian?
I mean, I think thanks, Sharon, that was very helpful. I think the question is, what actions are we taking to improve these numbers?
Sure. I think the strategy is really important. And I think I remember talking to Steve G, and he was saying about we've got to make sure that our strategies are different this time. We've got to make sure they're not just sitting on a shelf. We've got to have them engaged, long kind of process of engagement with people. So already by doing a few of those sessions, we've found some beautiful things that have come back to me overnight about where things are improving, because people are having some different and some challenging conversations. So things from like our Compassion in Action program, where people not just do an ED&I course, they have those kind of, so what, now what are you going to do? How do you have those challenging conversations? So we've got to do far more of that. Reverse mentoring, the reasonable adjustment work. So there's a lot of things in the action plan that we're doing. I don't think we're doing enough as an organisation or as an NHS, because we're still seeing it across a lot of the public sector. So we have to really constantly ramp up and never let our foot off the accelerator. It's hard work.
Let me bring in Pri, and then I'll come to you, Steve.
Well, I want to thank Sharon, first of all, for the reports and for presenting today. And just to highlight, I guess, some of the points that she's made, this area is it's the whole trust is responsible for what we do, and to make sure that all of our staff, whether they have protected characteristics or not, do not suffer any detriment, that they're protected personally and professionally from any discrimination. These reports do come through to the People and Culture Committee, and we are very conscious that we need a really robust overall strategy, and that it needs to link to the Trust's overall strategy for it to really make a difference. But I would like to highlight that, our belief is that everybody takes some responsibility for this, regardless of where they are within the Trust. And I'll leave it at that. Thank you.
Thank you, Steve.
Yeah, thank you, Sharon. Really helpful to see it. It was just back on the actions, really. I think I counted nearly 60 actions across the 2 action plans, and I just wonder whether you've been able to sort of look at prioritising to maximise the impact of the actions, or whether you think they can all be achieved in the timelines, which I think is this financial year.
No, it's a great question, thank you. And we got asked this, I think it was in one of the other boards, I think it could have been People and Culture, and another Ned asked us, she'd counted I think 40, so I think we've scooted 40 over into our action plan, into our operating plan, and what we're doing is cross-checking all of those. So I think, as Pri just said, they're not just our actions, so a lot of these are already being addressed in our partner areas, so L&OD, freedom to speak up, so we work really well together around triangulation, etc. So I think it was, I'm trying to think who it was, said this ED&I strategy, and me in terms of this role, I'm a bit like an air traffic controller, so it's about pulling in, making sure where they go, making sure we're checking off, doing things, and constantly trying to make sure we're checking off everything in that action plan. So I think we've got to remember it's over 3 years too. So the priorities are reasonable adjustments. We've had people waiting over a year to get reasonable adjustments and equipment within the organisation. So even though people say it's good when they get them, we're having people waiting far too long, for HR processes. And I think, Stephen said we're doing some deep dives, etc. Looking at the res and dares, the staff survey, and linking that to NOF, etc. And what was the other one? In terms of board, so it'd be good to mention that here. There's some board objectives that we need to have some help on, and that's making sure you have very smart objectives for ED&I, and they're very tangible. I know CQC talked to me a little bit about that, so we need to make sure that we can talk to that, we're seeing that, we can monitor that as an organisation, what actions the board is taking. So that's some of the things we need to do, and have 100% on our ESR, I think, in terms of our demographics, we all need to make sure we're updating those. So they're the things we think are quick wins where we can make a difference. And here's some of the stories coming back from our staff too. So some of those real positive stories.
Bring in Karen.
Thanks, Chair. Just to pick up on the point that Pri's made, but you've also touched upon it as well, Sharon. I see priority area number 1 on the appendix, page 15, talks about the board, as you've mentioned, having EDI objectives. I suppose my question and challenge is, we've got a significant number of very senior managers, and I've seen that data somewhere else, in excess of, I think, 90. Why are we not being a bit more brave in giving all of them an EDI objective? Because it's everybody's responsibility, not just the board.
You're absolutely right. So I've been setting objectives, setting KPIs this morning. So I've actually tried to do them in terms of different professional groups, TLT, to make sure everyone in TLT has done a round of reverse mentoring. However, the bit that I want to come back on and challenge just slightly, Karen, is we have the NHS ED&I improvement plan, and that specifically states board and NEDs in there. So it talks about in that, of course, we want to do what you're saying in terms of our senior leaders, but it talks about making sure that the board have specific ones. So we don't have a place that we take that to, but we have to do, and the ED&I improvement plan. So we've got that. It may be good to bring it here, but it specifies around the board. So that's why we're just wanting to make sure that we do that, Karen.
All right, so lest anybody should be worried, to be assured that everybody on the board has media objectives.
Beautiful.
So that's what we would expect, both individually and collectively. Steve, do you want to come in?
Yes, please. Sharon, thank you for your report, and I think Bree, thank you for your statement, because Steve's point about having an action plan at the back of a document is incredibly important. But this is the business of every employee in the organisation, and this is about making sure that this is a fair place to work. It is a positive place to work, and we remove discrimination from our vocabulary, because arguably what we don't want to see is that displayed either with any of our clinical settings with our patients or our families, or indeed any of our employees. I think the bit that, Steve, to give you assurance on the 60 points in the action plan, talking with Stephen and Sharon, the bits that I'm really keen on actually is the delivery of that is one thing, which I think is super important. But I want to know a couple of really simple things, and not for now, but for outside of this. I want to know what we're doing and what's getting in the way. And they're the two questions I ask. And if it's within our gift and it's in our way, then we can fix it. If it's not within our gift, then we find a plan to fix it. And I think that's the trajectory that we're on. And I think there is, Chair, also, just for the minutes, actually, Sharon, there's some really positive things in this report that we mustn't lose sight of. So every NHS organisation will, I'm sure, experience challenges over recruitment and retention and some of the issues that you've highlighted. But there are some really positive steps and green shoots that we can see here, which I think are the ones that we need to hold on to and we need to focus on developing and nurturing. And then arguably keep a check on through regular reports through our People and Culture Committee, which I think is really important. So I just want to say thank you for producing the report.
Excellent. I mean, there's one theme that we haven't drawn out where I think we need to do much better. Well, the NHS needs to do much better, but some places are being more activist than I observe with us, which is about the abuse that staff have to deal with. And sometimes that moves from abuse into violence. I think we need much clearer messaging and support for people around how to deal with this in practical terms. And I know we've signposted to other places that are quite activist in this, and I think we should commit to getting better at it. So I think as a board, via People and Culture, it would be good to just hear a bit more about what we can do, what we are going to do. I think, Pri, I'm looking at you for that.
Yeah.
Okay. Can we move things along then, if everybody's content? So thank you very much, Sharon, for that work. We will keep coming back to it. And move then.
Lovely, thank you.
To you, Steve, for the Business and Performance Committee Assurance Report.
Thank you, Chair. So as Evertech the report has read, and this is a report on the Business and Performance Committee meeting on the 20th of August. We spent a bit of time on finance at the meeting, as you could expect. So, but I think we've covered much of the content in the finance item a little bit earlier. The only thing I would add is that we have asked and are receiving regular monthly reports, not waiting for when we have a committee. So as soon as for example, month 6 is available, that will be shared with us, which helps to keep us up to date and aware of any new issues that arise. Other areas just to highlight on the operational risk register, there are 4 new risks that we've agreed to take on. 2 of them are operational, one around the supply of medical devices transferring at short notice from one supplier to another. That was managed, but it's something that we'll be keeping under review and a close eye on going forward. The second is around the use of personal vehicles for patient transport. That's been suspended pending review, and again to understand insurance issues, but also understand why they're used, and again something that we look forward to seeing progress on with that review. We've spoken about out of area placements, so the only thing to add is from a BNP perspective, we want to see the focus on the number of bed days and the cost per bed day. It's not about money it's about better quality of care as well. But we're looking at it from that perspective at BNP. Another area to highlight is the service review for community mental health and children's services, which has been commissioned by the ICB. Really important piece of work happening at pace over the autumn, and I know that we're heavily involved in providing data and helping to lead that work, and it's something that we spoke about last time, and I'm sure we'll hear about again in October. Just important, I think, to flag that work. Two other areas, positive news really on FOI. It's really great to see the number of responses within 20 days go up from 71% to 86% quarter on quarter this year. That's really good to see. And on research and innovation, again, very positive. We've heard about the university status earlier. Some really strong and positive stories that came through feedback at the meeting. We have a Peterborough presence now for research and innovation, a part-time presence, which again is really great to see. And we did ask BNP if next time we can have a focus on the benefits for CPFT from that research activity, that would be bringing it alive even more. So those are the sort of highlights, Chair, BNP.
Thank you. Before I open things out, can I just, this is very fresh in my mind in terms of one or two services that are impacted by this. The use of personal vehicles to transport patients, this has been under review for a number of months. It doesn't impact that many service areas, but where it does, it's causing difficulties. So how many months does it take to review an insurance position, is my question.
Good question.
So it's not, we're very clear on the insurance position. What we're needing to understand is from every service why they are transporting patients, and what other options are there. So we are very clear on the insurance position in that people aren't covered through business, their own business insurance to transport patients. We've found that this is a much more widespread occurrence than we initially thought. So we are having to go out to every service to say, do you transport patients? If so, where, what and why? And actually, what are the other options available? So we're being supported by our estates colleagues in quality and safety colleagues as well to do that work. So currently we're waiting for the responses back from the services.
Okay. Well, if we could hurry it along, I think that would be helpful, Holly. Questions on Steve's report? Mike?
Yes, so out of area placements, sorry to come back to that, but it's one of those areas where a quality impact assessment, the quality of care is improved if you don't have out of area placements, as well as saving money. So I'm kind of keen to find quality impact assessments that improve quality, as well as those that might have an adverse effect. But I am right in thinking that whilst we're doing well, we still have to send female patients out of area because we don't have a female psychiatric intensive care unit in this county.
Yes, you are, and another cohort of patients are locked rehab provisions, so we don't currently provide locked rehab. That's not a service that's commissioned by RIs.
The reason I'm raising it is just to keep it at the forefront of our minds, because it's not only a financial issue, it's an inequity.
I've made this point to the new super ICB that we're joining, Central East. I met with the chair, and be assured I took the opportunity, and it won't be the first and only time I do that, to draw to his attention that these are issues of profound inequity, and I'm not sure they're even legal in terms of the gender disparities in service provision. Steve?
I think I won't comment on that because I wholeheartedly support you. I think, Mike, the point of our reference back to out of county, we need to, and I am assured that this is happening, but we also need to link this now to our conversation on length of stay, because our length of stay is higher in some areas than I guess we would like it to be. And I know there is a significant amount of work within the directorates to target that. Some of the national averages, for instance, sit between 45 and 33 days. We sit above this. And so one of the conversations that I want to start having very quickly with the team is, what are we doing around this length of stay within the functional model that we've got at the moment and the actual service model that we've got at the moment? Because when we start talking around margins and talking about changing of models, if you start changing those models, which we probably will look to do, we need to do that incredibly safely with a significant amount of oversight and support from you themselves. That said, if I look back, length of stay is too high in this trust, and therefore we need to think about what we're going to do to bring that down. And then by default of bringing that down, our out of counties will continue to be sustained. The services that we don't provide yet, which mean that people do have to travel, is something that we do need to continue to talk to our commissioners about, because as Eileen quite rightly says, it feels unethical for people to have to travel out of county, be away from loved ones and experience care in other providers when actually they could be cared for in a local institute that looks after them and they're close to their families.
And we need to remember that out of area can be very significantly out of area. It's not just an adjacent county that you're sending people to. Right.
So there was a report last year which talked about the outcomes of out of area treatments. And it's the only report I've read which has a health warning at the beginning that this might be a distressing read.
Yeah.
So outcomes, suicide, etc. rates are higher if you do this, which is why I'm overall quality and safety.
We will keep at it, Mike. And I'll keep at it as long as I'm here. Kish.
I think just on the turning this into a practical, want to do something about it, then get the business case about what we want to do approved ahead of any funding that comes. So you're ready to go.
Yeah. Excellent. Any more on the report, which is very thorough, very helpful, and it is good to see the improvement in FOI. I want to keep seeing it edge further up, but that is brilliant to see progress. Steve.
Sorry, yeah, it's a question, if I may, of Steve and Holly with medical devices shift of provider. Can I just check if that impacted on any of our services? Because I know it significantly impacted on another provider, which we had to support. But was that mitigated from our perspective?
So we did mitigate it. We put in place an escalation process. So there were a number of items across our community services, and in particular affecting some of our children and young people services that actually haven't been transferred over. I have to say the response was very quick in terms of once we raised it, it being addressed. We are still, I think it's fair to say, we are still monitoring that situation, because whilst the majority of items that we regularly order, we've got no issues with, there are some of the slightly more obscure items that as we come to order them, we're recognising aren't on the list. But we do have good engagement, and actually I think across the system we support it well.
Okay, that's helpful. So Holly, we are staying with you. The operational performance report.
Indeed,
a number of annexes to it today.
Yes, I will try and be brief and not cover points that colleagues have already highlighted. And I'll take the report as read. So it obviously provides an update on the operational performance for the month of August. I think it's useful to highlight, Steve mentioned the national outline framework. So we are currently looking at our KPIs so that we can ensure that we are including the NOF, as it's globally becoming known, in our regular reporting. And we have included as an appendix a briefing paper for those of you who might be more interested in the NOF, but particularly where we come. We have met with all of the directorates and looked at their individual performance, and we have identified what we need to do in order to improve our segmentation, and we've now got weekly meetings to review progress. And obviously one of those is particularly around some of our long waiters in our community services. I will just mention a couple of waiting lists and some successes that we're seeing. So in children's, young people and families, just would like to highlight speech and language therapy. So the team has done an internal piece of improvement work, which has resulted in an overall waiting list reduction by 20%. We still have some very long waiters within that cohort. So that is our next area of focus, and we will have a trajectory which we will take through both quality and safety and BNP, specifically highlighting how we get below 42 weeks. But I do want to acknowledge the improvement of a 20% reduction in that service. Another piece of work that's been done is around the pathway for school-aged children awaiting a global developmental assessment, sitting under community paediatrics. So actually we are changing who has those global developmental assessments, because what we've recognised is that the majority of people who have them then get referred on to CAMS, and actually we've put an additional step that actually isn't helping their pathway or their sort of assessment and treatment. So with the support of all of those teams, we've replaced the global developmental assessment by a developmental history, which is taken at point of referral so that direct referrals can be made. And we're hoping to see quite a dramatic increase in reduction in waiting lists, because people will be going to the correct services first time rather than going through an additional step. We'd also like to just mention the clozapine virtual ward. So as Mike mentioned, we're really proud of that service, very innovative, and at the last adults performance and risk executive, we agreed to extend the patient cohort that were being offered the opportunity of clozapine via our virtual ward. So again, that means that we'll be able to help more patients in a more timely fashion. So is a good news story. I think people might have noticed that diabetes and WAFT shared their intention to give notice on the consultant provision for our community diabetic service. We've had several meetings with both the ICB and MWAFT. MWAFT, whilst they have formally given notice, have made it very clear that they won't be removing that resource until we have a newly defined pathway. And currently our two operations directors are working together to look at an interim pathway for the next 6 to 8 months. But the ICB have stated their intention to recommission the entire diabetic pathway right across Cambridge and Peterborough. And it's most likely that we'll see the introduction of pathways that have been developed in HWE. So we are doing a bit of reaching out to colleagues to understand what that looks like, so that we can be in a good position to make comment when that's suggested. I think that's where I'll finish, but happy to take any.
Right, questions for Holly?
Just one, please, and it's not really a question, Holly. It's I think worthy of note for the minutes that within your report is the update on the town hall, and within the town hall, in part of the appendix, is the Peterborough Town Hall RAC review, the reinforced air radiator concrete review. Colleagues will be aware that we as a board took a decision to protect the safety of our workforce after the publication of a document by the council that talks about the building being unsafe. Therefore, we asked staff to leave that building and try to provide services from an alternative accommodation. It's safe to say that the alternative accommodation is not ideal in terms of the service provision. However, we apologise for any inconvenience that caused, but the statement associated with the risk of fatality with the building that was made public was something that we needed to take very seriously. So I think to take it on note is a thank you first to Alison Manton for commissioning through NHS England the expert review, which is included in the appendix for assurance. Secondly, to the directorates and the team for taking it very seriously. And then thirdly, actually for the service itself that had managed quite a lot of disruption over a period of time and is still in a building that is obviously requiring work to bring it up to standards. But I think if the board was reflective over the decisions it took and now the assurance that it has, being able to then reoccupy that building with this level of assurance with the team having sight of this and discussing this with the engineers is really important. So I just wanted to make a formal measure of thanks for those three colleagues, for bringing good sets of colleagues.
Thank you. I will just draw out a couple of things myself. I am pleased to see that we're making some progress on speech and language therapy for children and young people, but I can only restate how important it is for the way in which a child is able to progress in life, that they get access to services really speedily, particularly for younger children. A year comes at a huge cost. So we've just got a duty to get these figures down. And the other thing that I always draw out is about those with learning disability. How are we prioritising getting people through those weights? Because again, if you think about impact on individuals and their families, it's a group that is often highly stressed and stretched. And we've got, again, a duty to do even better by them, Holly. So I've been looking for some assurance that we are really making some progress there. Okay. We're noting the RAC report on which I provided some feedback. We're noting we've got a paper on the National Oversight Framework, which becomes really for us the pointer towards the things that we must prioritise. Everything else becomes a luxury good, frankly. It is giving us the areas that we really must focus on. So therefore, we then move, I think, Steve, back to you for a report on the Children's Hospital.
Thank you, Chair. I'll be brief and highlight some key points. So firstly, we had a meeting of the committee last week, so there are 1 or 2 updates on the report that's in the pack. First thing, the submission of the full business case has been put back to September next year, September 26. Main reasons have been the design clearance from the contractor employee, which I'm pleased has made good progress, but also some of the uncertainties in compliance with the Building Safety Act that require more work to be done. But that's the revised programme, which would lead to building completion in 2030. Some areas just to focus on the joint venture, which we've spoken about before, for the build, operation and maintenance of the building. We discussed that last week and reminded the hospital team of the need for us to see progress from the workshop that we had in the summer, early summer, and the concerns we had around governance. So we are expecting there to be a further workshop with updates of progress in October. I don't think we have a date yet, but the programme, the overall programme delay means that a joint venture decision that we need to take is not needed this calendar year and can be taken in January, but we still need to have a good run up to that to make sure we're comfortable with what's being proposed. Joint endeavours, this is to look at the clinical and operational governance once open, and I know some colleagues, exec colleagues particularly, have been interviewed by a company called Stratis, who are looking at those options. Really important piece of work, again, that we'll need early sight of as a board because it will have implications for CPFT as well as for the hospital itself. Others may want to comment on that. We do think we should be broadening the engagement of strategists beyond those that are currently on the list, and I'm sure one or two NEDs would be keen to talk to them. Third area, the Ida Darwin site. This is something that is particular to the CPFT. I know that we've written to Homes England to extend the current lease arrangements to coincide with the programme changes. I think we're waiting for a response from Homes England and pressing hard for that. And we'll be supporting Alison if she needs help from the board on that. A couple of other final things. The Front Runners programme, which is demonstrating how services, physical and mental health services, can be integrated in advance of the hospital itself. The first cohort concludes with a presentation in early November, which will be great to see. And we agreed last week that we should be pushing for more mental health submissions for future cohorts. And finally, on risks, we had an update on project risks, and I think very clear action for us to get a clearer visibility of CPFT risks. We will have come back to our next meeting in October. Those CPFT risks that are a risk to the project, but also in reverse, risks that arise from the project for CPFT. And it's really important that we have clear visibility. And I'm pleased that Jim Ledbetter is going to be working with the Children and Young People's Directorate to bring that risk register back for our next meeting in October. That's it.
Super helpful, and I do think it's really important that the company doing the work engage with rather more people than it has done. So I don't know how we're getting that message to them.
I emailed them after your comments previously at the meeting, so I emailed the company as well as Malcolm as the programme director. So
bless you. Okay, so hopefully that should be happening. Okay, all right, thank you. So much to do there. It remains a very important project for us. So Kathy, we stay with you. Your annual report on how we're working within mental health legislation.
thank you, Jo. So this covers the period April 24 to the end of March 25. And overall, I'd say compliance remains very strong. And there's some key risks that we are continuing to monitor, but also some areas of notable progress and good practice. So just some key highlights. Mental Health Act detentions rose by 2.6%. That's in line with national data. We've continued to have patients detained out of area, so going to out of area beds, 134 during the relevant period. But in recent months, we've seen a significant reduction in that, which is very good news and aligns with the work that's been done on reducing out of area placements. In terms of ethnicity, we continue to see a disproportionate detention of Black patients. In the trust, it's 2.6 times higher than white patients. Again, that mirrors the national picture. And what we're doing is looking at that data through the lens of PCRAF, the patient care race equality, to try and better understand that data. So it's a key area of focus. One area that we're also having a bit of a deep dive on is redetentions. So we've had a fairly significant increase in redetentions within 6 months and 12 months of discharge. And so the mental health law team, along with our clinical leader, are looking at that currently. The use of Section 136 is down 8% in the system, which is good news. There's been an increase in activity in the CPFT suite, but a decrease in the emergency department. And that, again, is probably a good news story because it means that there's a more appropriate diversion of patients to the mental health facility. You will see in the report that the 136 suite was unavailable 75 times during this time frame. The reason for that, in 63 cases, it's because the suite was occupied already, so it was about demand. And then there have also been clinical reasons for not accepting patients in the other cases, and that's usually because it's deemed that the patient requires physical health treatment, and the safest place, therefore, is to go to the emergency department in the first instance. So the other sort of risks that we're looking at, we continue obviously to have bed pressures. The availability of Section 12 doctors is another issue, and that's monitored by the ICS. Mandatory training compliance has been a problem, but we're now on track to achieve 90% compliance this month. We have some staffing vacancies, but apart from that, there are no significant risks. And I'd just like to highlight some positive areas of practice. So the mental health law team, we have a huge number of policies. They will be reviewed, and they're now doing an overarching policy supported by a service operating policy. And that's a really good way forward, actually. We've also had some very useful support from the business informatics team and our tech colleagues. So we've managed to improve the functionality on System 1 for recording issues relating to mental health law practice. So, for example, patient rights, reading, laws applications, Section 17 leave. We also have a new Power BI dashboard, and I can't tell you how important that's been, because the team have been using spreadsheets up until now, doing everything manually. So that's really, really helpful. And then I'll end on the other good news story, which is that we have managed to put 3 non-psychiatrists through the training to become responsible clinicians. They've now completed their training and they're working as responsible clinicians with some.
Just explain what that means, being a responsible clinician.
So these are people who can actually oversee the care of patients who are detained under the medical.
Very helpful. Anything else you want to add?
Not really, no.
No? Okay. Questions, observations for Kathy? Mike? And then Rudolph.
So just draw out the issue of inequality again, and the fact that there's a disproportionate representation. And that does align with the work we're doing on PCREF and the equality. It's just a theme that seems to be emerging, that it's not just about numbers, waiting lists and all of that. It's about fairness and justice.
Absolutely, and looking at things through the lens of inequality.
Yes, and that plays into the strategy, the clinical strategy. And the
Rudolph.
Thank you. And of course, there are questions on saying that, so absolutely. The temptation to think it must be our services, but it could be before our services. But yeah, let's keep that in mind. So I was just going to ask about the Section 136. This is the police power that are going down. There have been some reports elsewhere in the country of adverse outcomes occurring because the police have not detained people. Is there any indication that we have any such incidents locally, and would we know if there were?
So I think that might be something Holly might want to comment on. So I can't, there's no evidence that, I mean, we've got an 8% reduction. I suppose what we don't know is who we're not seeing. But the relationships between the police and CPFT are actually very positive. And I think unlike a lot of areas around the country, they continue to be very supportive and responsive. Holly, I don't know if you want to.
Yeah, so I think as part of the police initiative in terms of right care, right person, we have built on existing really good relationships. We've done a number of training sessions around with our police colleagues around sort of an appropriate use of Section 136, because between sort of 75 and 80% of people pre-right care, right person coming to weren't referred on to any mental health services or detained. So we knew that we had a gap in terms of knowledge. We've also got somebody based, obviously, in the control centre. So actually having somebody who can speak to police officers on scene, listen to what's going on, provide alternative advice, etc. So I think that overall, I know that other areas of the country have really struggled with right care, right person. I don't feel that we have. We still meet on a monthly basis to sort of understand if we believe that there are any sort of quality, safety or harm issues. We haven't highlighted any, and certainly both Section 136 staff and our crisis and FRS team feel that it's been very positively implemented in Cambridge and Peterborough. They took a very slow approach. which actually other areas in the country didn't.
I think that's a very good point, and I think what we can do is go back and look at the data from previous years and see the point at which we introduced the initiative, whether or not we're seeing a change in trends, but it may be that it's much more appropriate. Your suggestion.
Super. We are at the end of the agenda and sadly out of time. Did anybody want to pick up on anything not covered? Steve?
Just one very brief thing, Chair. I think it's probably worth it. Maybe this is a personal reflection, but colleagues may have noticed that the National Lead for Mental Health, Claire Murdoch, stepped down from role not so long ago. And I think I would want to put on record my thanks for her contribution to the sector and wondered if board colleagues would like to join me in saying that formally.
Certainly want to endorse that. Claire has been a great champion over many decades for mental health services, and she is going to be much missed. Her advocacy and her passion, as well as her sheer knowledge of what actually happens on the ground, has been an enormous asset. She's given time and dedication to it. Very, very hard to replace somebody like that. So thank you for drawing that to our attention. And I think I thank everybody who's joined us today. Lovely to see you. You will gather there's a lot on at CPFT. There's a lot on in NHS. We have to keep on doing the right things because at the end of the day, we only exist to serve people. That's what we must come back to. People serving people. So thank you for your time. Appreciate it if Nat and Karen could just hang on as